Welcome to this video on perfusion. We will begin with the anatomy and physiology of the heart. The heart is enclosed in the pericardium, and its wall consists of 3 layers of myocardium. Key structures include the atria, ventricles, and valves, which are crucial for blood flow. Let's review the path of blood flow through the heart. Deoxygenated blood enters the right atrium, moves through the tricuspid valve to the right ventricle, and then through the pulmonic valve to the pulmonary arteries. After oxygenation, blood flows through the pulmonic veins into the left atrium, through the mitral valve to the left ventricle, and finally through the aortic valve to the aorta for systemic circulation. The heart has specific anatomical landmarks. S1, or lub, marks the beginning of systole as the AV valves close, loudest at the apex. S2, or dub, marks the beginning of diastole as the semilunar valves close, loudest at the base. A normal heart rate is 60 to 100 beats per minute. An increased heart rate, known as sinus tachycardia, over 100 beats per minute, decreases filling time and increases oxygen consumption. A decreased heart rate, or sinus bradycardia, is less than 60 beats per minute. Hyperlipidemia, or high cholesterol, is diagnosed through assessment, history, and a serum lipid panel. This panel measures total cholesterol, triglycerides, and phospholipids, including high-density lipoprotein, HDL, and low-density lipoprotein, LDL. Cholesterol, a blood lipid, is a risk factor for atherosclerotic heart disease. The normal level is 140 to 200 milligrams per deciliter, varying with age. Triglycerides, a mixture of fatty acids, have a normal range of 40 to 190 milligrams per deciliter. Lipoproteins include LDL, known as bad cholesterol, and HDL, or quote, good cholesterol. You want your LDL to be low, with a normal level under 130 milligrams per deciliter without CAD, or 100 with CADAD. You want your HDL to be high, with normal ranges varying by sex. Cholesterol treatment includes lifestyle changes, dietary modifications, and exercise. Medications like statins, gemfibrozil, niacin, cholestyramine, and ezetimibe can also help lower lipid levels. Arteriosclerosis is defined as the thickening, loss of elasticity, and calcification of arterial walls. Risk factors include diabetes, high cholesterol, smoking, thrombophlebitis, obesity, prolonged sitting or standing, and a history of DVT. Clinical manifestations of arteriosclerosis include pain, such as intermittent claudication, and rest pain. Other signs are decreased sensation, reduced or absent peripheral pulses, color changes in the extremities, and edema. Diagnostic tests for arteriosclerosis include segmental pressure measurements and stress testing. Imaging options are Doppler ultrasound, duplex Doppler UTS, transcutaneous oximetry, and angiography or magnetic resonance angiography. Treatment focuses on smoking cessation, proper foot care, avoiding constrictive clothing, and regular exercise. It is also important to control underlying risk factors, such as diabetes and hypertension. Surgical options for severe symptoms include percutaneous transluminal angioplasty and stent placement. Other procedures are arthrectomy, which removes plaque, and endarterectomy. Coronary artery disease, or CAD, is a term for conditions that obstruct blood flow in the coronary arteries. Atherosclerosis, characterized by yellowish plaques, is a common cause. CAD is the leading killer in the U.S., with risk factors including smoking, high cholesterol, diabetes, and obesity. The heart relies on the coronary arteries for oxygenated blood. An MI often impacts the left ventricle due to its greater muscle mass and higher oxygen demand. Symptoms may not appear until about 75% of the affected vessels are occluded. Coronary arteries, branching off the aorta, include the right coronary artery, left anterior descending, and circumflex. These arteries supply the heart muscle with necessary oxygenated blood. We now focus on hypertension, which involves risk factors like family history and smoking. Causes include kidney disease and arteriosclerosis. Complications can range from heart failure to renal failure and CVA. The primary treatment goal for hypertension is to keep blood pressure within normal limits. The first step involves diet and lifestyle modifications. The second step is medication, typically a diuretic or beta blocker. The third step involves adding other antihypertensives. Common medications for hypertension include calcium channel blockers, ARBs, beta blockers, and ACE inhibitors. Other options are HCTZ, spironolactone, and clonidine. Nursing management for hypertension involves monitoring blood pressure consistently using the same cuff and location. It is important to keep a record of BP and lifestyle changes, teach clients about medication adherence, and emphasize the importance of BP control. Next, we will discuss pulmonary embolism, or PE. Causes include DVT, atrial fibrillation, and fat or air emboli. Risk factors involve surgery, immobilization, a history of DVT, smoking, and obesity. The classic triad of PE symptoms includes dyspnea, chest pain, and hemoptysis. Other clinical manifestations are anxiety, tachypnea, tachycardia, fever, and changes in mental status. The diagnosis of PE can be challenging due to minimal signs and symptoms. Diagnosis of PE uses tests such as CXR, VQ scans, D-dimer, and spiral CT scans. Treatment goals are to prevent DVT growth and provide cardiopulmonary support, including oxygenation, pain management, and anticoagulant therapy. Medications for PE often include warfarin, an anticoagulant, and diltiazem, a calcium channel blocker. Peripheral vascular disease, or PVD, involves abnormal conditions affecting blood and lymphatic vessels outside the heart. This includes arteries, capillaries, and veins. It is categorized by modifiable and non-modifiable risk factors, and whether it is arterial or vascular. Clinical manifestations of PVD include intermittent claudication and decreased peripheral pulses. Patients may also experience color and temperature changes in the skin, hair loss, reduced capillary refill, hardness, edema, and numbness or tingling. For assessment of PVD, remember the acronym PATCHES. This stands for pulses, appearance, temperature, capillary refill, hardness, edema, and sensation. Medical management for PVD focuses on relieving symptoms and promoting adequate circulation. Goals include healing and preventing tissue damage, reducing edema, and treating ulcerations. Finally, we discuss deep vein thrombosis, or DVT. The etiology is linked to Virchow's triad, which includes pooling of blood, vessel trauma, and coagulation problems. DVT is categorized into superficial thrombus and deep vein thrombus. Let's distinguish between a superficial thrombus and deep vein thrombosis, or DVT. A superficial thrombus forms in a superficial vein, while DVT develops in the deep veins of the arms, pelvis, or legs. DVT can be spontaneous or result from trauma, with the legs being the most common site. Signs and symptoms of DVT include dilation of superficial veins, cyanosis of the foot, and tightness or heaviness in the leg. You may also notice a cool and pale extremity. A serious complication of DVT is a pulmonary embolus. Treatment for DVT involves bed rest, elevating the extremity, and using TED hose. For superficial veins, warm soaks may be applied. Other interventions include thrombectomy, which is the surgical removal of the clot, and the placement of a filter. Anticoagulant medications like Levinox, heparin, and Coumadin are vital in DVT treatment. Monitoring labs like PTT and PT is essential. Thrombolytic drugs such as urokinase and streptokinase may also be used. Other treatment areas include diet, emphasizing adequate hydration. Activity includes bed rest during the acute phase. Prevention strategies focus on early ambulation and avoiding crossing legs or wearing constricting clothing. Nursing interventions include monitoring vital signs and respiratory status, and measuring the circumference of the extremity. It is also important to monitor anticoagulants for signs of bleeding, elevate the extremity, remove stockings daily while in bed, and note any signs of pulmonary embolus. The signs of phlebitis may include a red streak, warmth, swelling, tenderness, or hardening. DVT symptoms can be subtle or absent, but may involve warmth and tenderness at the site, or unilateral swelling. A positive Hohmann's sign should not be assessed if there are obvious signs of thrombus. Pregnancy-induced hypertension, or PIH, is the most common hypertensive disorder in pregnancy, occurring in 2 to 7% of cases. It is defined as an increase in BP after 20 weeks gestation, accompanied by proteinuria and potentially severe edema. The severe form can progress to eclampsia. Mild PIH exhibits few symptoms beyond elevated BP, proteinuria, and edema. Nursing care includes bed rest, preferably on the left side, daily weights, monitoring for headache, visual changes, or epigastric pain, daily urine dipstick for proteinuria, monitoring BP, and a high-protein, low-sodium diet. Severe PIH is characterized by a BP of 160 over 110 or higher and significant proteinuria. Nursing care involves strict bed rest and a high-protein diet, along with the administration of medications such as magnesium sulfate, corticosteroids, and antihypertensives. The ventral septal defect, or VSD, is an opening between the ventricles that can cause conduction problems. Blood flows from the left ventricle, mixing with unoxygenated blood in the right ventricle, leading to hypertrophy and pulmonary congestion. Symptoms of VSD may be absent with a small defect, but large defects lead to right atrial hypertrophy, fluid overload of the lungs, a loud murmur, and signs of congestive heart failure. Diagnosis is made through CXR, echocardiogram, ECG, and cardiac catheterization.